Okay, number of people have joined the call, and I think we can get started. I want to welcome everyone to our series on strategies for addressing the COVID response in low and middle income countries. This has been put on by the Center for Global Health at Johns Hopkins University. We've been doing this since March. This will be our last session for this summer, and we will then take a pause, if you will, and we will be announcing a follow-up series sometime this fall, which will be entitled COVID and Beyond for low and middle income countries. That is our primary audience. I want to thank everyone for joining our series, which started out twice a week and then went to weekly. It's really been a wonderful experience for everyone involved. Now, a few rules before we get started. At the bottom of your screen, there's a chat box. You're welcome to identify yourself, send greetings to others, but do not put your questions or discussion into the chat box. Instead, please use the Q&A box, which is on the far right of your screens if you're using Zoom. So I'll monitor that during the course of the presentation. I want to, again, thank our speakers today in advance for taking time out of their busy schedules to address an important topic. Professor Krishna Rao at Johns Hopkins will be leading off the presentation and introducing our guests. The title of this presentation is Responding to COVID-19 in a Pluralistic Health System: Readiness of Formal and Informal Primary Care Providers in India. So this is a very important topic. As you all have heard, the epidemic has massively expanded in India this past week. So this is very timely. Krishna, thank you very much for taking the leadership on this presentation. I'll now turn it over to you.
Thank you, Tom. I think we'll start with a few quick introductions. As Tom said, I'm Krishna Rao, an associate professor in the Health Systems Program in the Department of Natural Health. And the studies that I'm going to present is from ongoing work in Bihar that we have been doing over the last couple of years. I'll let my two other colleagues, Rajesh Jha and Karima Khalil, introduce themselves now.
Hi, good morning, good evening, wherever you are. This is Rajesh Jha. I head the Center for Health Policy in Bihar, which acts as a policy and research think tank to the Health Department of the state government.
Hello, I'm Karima Khalil. I'm a physician based in Delhi with Oxford Policy Management, and my area of expertise is facility-based services for maternal health, quality of care.
Okay.
And thank you for allowing us all to be here. Very glad to be here. I'm going to switch my camera off because everything freezes when I have it on.
I'll be doing the same. Thank you. Welcome. Krishna, back to you.
Yeah. I see Priya Nanda on the call. Priya, do you want to say a few words before we kick off?
Hi Krishna. I'm not going to appear on camera. I just wanted to welcome all of you to the seminar, and I'm really excited that we are focusing on Bihar, which is a core area of our work at the foundation in India, and all our partners are here on this webinar. The studies that were done in a very opportunistic, prompt way post-COVID are really illuminating and confirming a lot that we already know around the fragility of health systems and health-seeking patterns, but also are pointing towards new ways in which we should be looking at delivery of primary healthcare post-COVID. And I'm also very appreciative of Rajesh Jha, who's going to also help us set the context for Bihar having a lot of expertise and knowledge of precisely the subject area for Bihar. Actually, all of the three panelists come with great expertise and very complimentary presentations today. So welcome, and back to you, Krishna. Very excited about this.
Okay, thank you, Priya. Right, why don't I hand it over to you at this point?
Krishna, you're muted, I think, or
Rajesh, can you?
there's Rajesh.
Yeah, yes, Krishna. I can hear you now. There was some lag. Can you hear me?
Yeah, can you please start? Okay.
Yeah. So, after the first case we had in India on 30th of January, I mean, all of us know the numbers and the way it has been peaking in the last couple of days. Those numbers are in the public domain, so I won't get into those. But what COVID has brought in is, two sets of collateral damages. One is a severe disruption in the economy, in the lives and livelihoods of the citizens, as we have seen across the globe as well, and a severe disruption in the way health services have been offered. In the early phase of the lockdown, we've seen about 50 to 90% reduction in OPD cases, reductions in almost all basic routine health services like maternal, child health, immunization, NCD services, reduction in the sale of drugs. For example, 73% decline in the sale of vaccines around the month of April and May, when we were at the peak of our lockdown over here. Coming to the national insurance program, the claims volume there fell by about 64%. And we did see a shift in the utilization patterns, between the claims from public hospitals and the private hospitals, where at the national level, there was a slight increase in the share of claims from the private hospitals. Planned care declined by about 80%, and the unplanned care nationally declined about 56%. These are the figures from the National Health Authority. And we experienced about 25% decline nationally in deliveries. Now, related to, within this larger ecosystem, in terms of response to COVID, it primarily began with an abrupt imposition of one of the severest lockdowns that we've seen. And this sudden lockdown did impact millions and millions of lives of migrants, daily wage earners. But I guess, in hindsight, one is always wiser. Now, whether lockdown in that form and shape was appropriate or not is a question that, one will keep on asking. But throughout the response, we have seen a good number of, positive policy measures by the national government. And I'll give you a brief overview of that before entering more specifically into Bihar. We've seen a series of direct benefit transfers for the poor and the needy, free supply of rations. There were efforts around doubling of collateral-free loans. Medical insurances were provided for up to 5 million, per healthcare worker. Liquidity measures were improved for the medium and small enterprises and for the non-banking finance corporations. More specifically related to, health supplies and commodities, there was a banning of exports as far as, masks and raw materials were concerned. There were concerns around the, flip-flops that happened related to those decisions. But overall, I mean, it was a timely intervention by the central government in terms of its policies related to export and exemption of, taxes and duties. Now, some of the things that could have been probably addressed better and that did impact, the early days of the COVID response was lack of clarity around the testing strategies. There were frequent changes in the approach. There was a lack of clarity around what to regulate, who to test, testing at what rates. Central government did, cap the rates at 4,500 rupees per test. And then the states, came up with their own individual rates. Now, such kind of a capping basically also to some extent, affected the kind of, response that one would have expected from the private sector in terms of participation for testing. And the question that, remains is it the best policy for the health ministry to completely deregulate COVID-19 testing, with the only condition being that mandatory reporting of, results to the central government database? There were also concerns around over-centralization of containment strategies in the early days of the epidemic, where states had little control in terms of the decision-making, processes related to those. Coming to the economy side, as I mentioned, there has been a severe disruption of the economy. The most recently released central government figures indicate that first quarter of this fiscal year, the GDP has contracted by about 24%. And, the biggest engine of the Indian economy, which is private consumption, that has declined by about 27%. Now, within this larger, country level overview, coming specifically to Bihar, I think the state right now is having a kind of a triple impact. COVID, this is also the time around which, more than half the provinces in the state are inundated with floods. And in the next month or two, we have the upcoming state elections. For our audience, just to give a quick overview of Bihar, approximately 100 million population. It has been over the last few years consistently, growing at about 10% in terms of the economy. And the growth has been, higher than the national growth. But despite this steady development, as far as the health indicators and the health infrastructure is concerned, that's an area where some significant amount of, efforts still need to be put in place. Specifically about COVID, we have about 141,000 confirmed cases until now, with 88% recovery rate, as against 77% recovery rate nationally. And, the positivity as of now is about 4.1%, and as against 8.5%. So if we look at these figures, the state does seem to have done reasonably well in terms of its responses to COVID, despite the limitations as far as, infrastructure and the entire health setup is concerned. On the policy front, as far as the leadership and governance issues are concerned, we've seen an unprecedented response from the state government in terms of a very concerted effort. Though in the early days, we saw, a kind of a knee-jerk reaction, which was understandable at that point in time, and lack of coordination between different departments. But over time, this has significantly improved, and we do see a coordinated response as we talk today. The entire response in terms of, testing and treatment has been driven by the state with hardly any private sector engagement. And as I mentioned, we've seen unprecedented state level leadership in terms of state and sub-state level, coordination, communication, mentoring, and follow-ups. They've taken this opportunity to fill up, some long-standing vacancies. Almost all the positions of surveillance officers are filled up. Positions of lab technicians in, primary health centers are being filled up at a pretty fast pace. And a couple of other interesting, strategies they've put in place are incentives for engaging medical school interns and postgraduate medical students for lending their services for COVID care and treatment. And they have also undertaken pretty significant efforts around community engagement and engagement with the self-help groups, not just in terms of their response to the social security aspects, but also related to like local, community linkages and follow-ups. As far as the testing is concerned, I mean, it has significantly increased, primarily driven by the antigen testing. But a very recent policy move that RT-PCR facilities would be, set up in all the medical colleges in the state, including the private medical colleges, and to ramp up, testing numbers. They've started engaging with the urban local bodies pretty recently to set up, testing camps to increase the numbers. Quickly, last couple of points before I end. On the treatment front, again, a very recent policy move on plasma donation and promoting plasma donation for treatment. They have announced a scheme for incentivizing, recovered people to donate plasma. Post-COVID recovery wards are being set up. It has already been set up in one of the Apex, medical colleges, and they would follow that in, in other government hospitals as well. And a pretty interesting, policy response has been to look at strengthening their mental health counseling and care facilities as a part of their overall COVID response. I would like to end with the kind of, nature of, engagement with the private sector. That has not been very proactive, neither from the government side or from the public provider side. Early days, the government did cap the rates of testing at a certain amount, 2,500 per test, but the government fell short of taking very proactive measures in entering into a agreement with the private providers and start sending their samples to the private sector for testing. And the private sector has been taking a wait and watch policy instead of proactively approaching the government. From the central government, I think it was around April or early May that they determined a framework for costing of treatment services in private hospitals to be included within the national insurance program. But Bihar, like many other states that we know of, was pretty less responsive in terms of trying to engage with the private sector for treatment. That position still remains in Bihar, with one change that they have finally decided and approved the rates for treatment in the private sector. And finally, as we saw at the national level in terms of increased share of claims from the private sector, in Bihar, that increase in claims from the private sector has been pretty substantial, and almost 3/4 of the total claims under the insurance program are coming from private facilities. They have really driven the effort in terms of resumption of routine services, while government hospitals continue to remain stuck with their response to COVID. Over.
Thank you, Rajesh. Let me. Okay, can everyone? So picking up from where Rajesh left, I'm going to talk now about the pluralistic health system in India, particularly the large number of informal providers that operate in the primary healthcare space, and how that might influence how a country like India should deal with a pandemic like COVID. So the main objectives of the study, which was funded by the Bill and Melinda Gates Foundation India, was to understand how much primary care providers and know about COVID-19 and its prevention and in the management of COVID-19 cases. And the reason why we focus on informal providers is, as you'll see, they make up a large share of the health workforce in India. So, for example, when we normally think about the health system, we picture it like the figure on the left, where you have this standard hierarchy of health facilities with community health centers, primary health centers, district hospitals, and so forth. But in reality, what the de facto primary care system looks like is more like on the right, where the majority of your health workers are informal providers, and the formally trained providers really make up a very small portion of the total health workforce. So for example, studies that have tried to estimate the share of informal providers in the health workforce have estimated about 56% of all health workers are informally trained. That is, they don't have any formal training with a defined curriculum. The other point to note is that India's health workforce is really diverse. There are many types of health workers who operate in this. There are those formally trained in Western medicine or allopathic medicine. There are those who are trained in Indian systems of medicine, who are known as Ayush clinicians. And then there are, of course, informal providers and also a whole range of lay health workers. So in this context of a very diverse and pluralistic health system, we have an epidemic that is spreading through the country. And the argument that I'm going to make here is that for any sort of, for a decent response or a strong response to the pandemic, all these types of health workers would need to be engaged. This is some figures from the study that I'm going to present to you, and this is from Bihar. If you look at the who people contacted first when they were sick, so this is from a household survey that was conducted earlier this year. You see that about 68% of patients visited a private provider compared to only 21%, say, who went to a government clinic. And when we look at provider qualifications, that's the pie chart on your right, what you see is that the majority of the providers, right, are informally trained. So 66% of the providers in Bihar are informally trained. And the importance of this is that when someone has COVID-like symptoms, such as a fever, a cough, perhaps breathing problems, the classic COVID symptoms, the first person that they would end up showing themselves to would most likely be an informal provider, okay? And so that makes understanding how these informal providers view COVID, how well they know to manage it becomes all the more important. Here are a few pictures from what informal providers and their clinics look like. In Bihar, if you look at the photo at the bottom of the screen, this was a clinic run out of a home where the clinician there was actually the local primary school teacher who also, in his spare time, would officiate as an informal clinician. This particular person, like many other informal providers in the state, had some experience training under a formally trained doctor, but he himself had no formal training. One can look at this in two ways, by saying that it's a terrible thing that people have to seek care with providers, informal providers without any formal training. But you can also look at it as saying that at least there is someone there who can give them some sort of medical attention. It's a very difficult thing to come to one side or the other on this, and even the state governments in India have sort of debated this issue a lot. But what is a fact is that they constitute the majority of the primary care providers in the country. More about our study. We had started a household survey in November, which was a representative survey of households in the state of Bihar, which is in eastern India. That's the map of the state. And what we did was we then asked each person who had fallen ill in the last month who they had sought care from, and we had identified the location and some of the contact details of that particular provider. And so when COVID started in Bihar, or hit Bihar, what we realized was that we had an opportunity of trying to understand how this vast army of informal providers actually are dealing with this epidemic. And so in between July 1 and July 15th, we started a telephone survey where we attempted to contact about 1,138 private providers. We managed to reach about 46% of them, which was about 524. And these 524 informal providers were spread across 224 villages. We also contacted about 23 public providers. These are medical officers based at primary healthcare centers. But as you can see, the response rate we got from them was quite low. Only 33% picked up the phone when we called them. This graph here shows how our survey fits in with the trend in the pandemic in Bihar. So we conducted this survey right before COVID-19 exploded over Bihar. So that survey was conducted between July 1st and 15th of this year. The lockdown in Bihar was imposed around March 25th, and this was part of the national lockdown. And it's one of the most severe lockdowns possible, I think, globally. So what we have, so the results that we present are from this initial phase of the pandemic. So a brief description of our sample. As I said, we have about 524 private and 23 public providers. It was a telephone survey, and these people were contacted via telephone. Among the private providers, we had about 423 informal providers, 55 providers who were trained in Indian systems of medicine. So these are people with formal degrees. And we had 42 providers who had an MBBS or a formal medical qualification. 91% of the public providers had an MBBS degree. The others had either an Ayush degree, or some were even dentists. Among the private providers, only, as you can see from the pie chart, 86% had no formal training, and only 3% had an MBBS degree. Most of the private providers resided in a village, while the public providers were not resident in the village or in the area where they worked in. In the series of slides I'll show you are essentially responses to questions we had asked these providers on the telephone. The question that was posed to them is listed along in the slide. So in this particular instance, we asked them if there's been a change in the number of patients coming to your clinic compared to what is usual. And as other studies or have shown, there has been a substantial decline in the number of visits coming to both private and public facilities. So about a 72% decline in private facilities and about a 65% decline in public facilities. So a substantial decline. We asked providers about if in the past week there'd been a change from what they usually observe in the number of patients coming with with the following symptoms, and these symptoms are what we would consider as classic COVID symptoms. For the majority of clinicians, both in public and private facilities, they did not report an increase in patients coming with these sort of symptoms. However, there was a much higher percentage of people coming with these classic COVID symptoms to public facilities compared to the private facilities. So putting this and the previous slide together, what we see is that there is an overall decline in the number of patients seeking care, but there's been a change in the profile in the sense that the number of patients coming to public facilities, a greater number seem to be having these COVID-like symptoms. When we asked our sample of providers where they got information on COVID-19, the top two sources for informal and private providers was newspaper and TV. There was very limited contact with government officials. On the other hand, public providers almost overwhelmingly said that their source of information on COVID was from the government. And so this highlights the sort of, and a point that I'll come back to later, the sort of lack of engagement, even in communication about the pandemic that the government has with most of the primary care providers in the state. When we asked providers what were some of the ways to prevent getting COVID, interestingly, the typical ways of prevention were well known across informal providers and formally trained providers, and so that was sort of a good thing. When we asked them what were the key symptoms of someone with COVID-19, again, most of them got the classic symptoms of cough, fever, breathing difficulty, but it was by no means universal. But other sort of symptoms which have subsequently become very important, things like loss of taste, smell, diarrhea, fatigue, these were not picked up by a majority of both public and private providers. And again, this I think points out to a sort of gap in the communication that has happened. We asked providers that in the past week, if a patient came to you with classic COVID symptoms like a fever, cough, or breathing difficulty, what would you tell them to do? Here we got a very diverse set of responses. Overall, if you look at sort of the history questions that they might ask, things like whether they had a pre-existing health condition or there are other people in the family with these kind of symptoms, only a minority of providers in the private and surprisingly even in the public sector said that they would ask these sort of questions. When it came to testing, about 70% of the informal providers said they would ask the person to get a COVID test, which is about the same as what a public provider would do, but by no means was this universal. And so this could either reflect a lack of knowledge, but it could also reflect a supply issue. Maybe there were no testing available in the area, and which is why about 30 to 40% said they wouldn't recommend a test. Similarly, when the key medical advice that is given, things like rest at home, wear a face mask, check if symptoms get worse, the majority of providers, and again, surprisingly, even in the public sector, did not mention these in their interview. How would they deal with referrals? Again, we asked them, so if a patient came to you with these classic symptoms, would you refer this patient or not? Interestingly, a large number of public providers said they wouldn't, the majority of public providers said they wouldn't refer them. But on the other hand, a majority of private providers said they would refer them. So about 44% of the informed providers said they would not refer them. And the common place that where referrals were said they would be made were to a government clinic or hospital. So this is how, in a way, they would manage a case of a COVID patient. So I'll quickly summarize the findings from this study. So one is that from our telephone interviews, there seems to be an important drop in the use of health services, and in this case, outpatient health services, both at public and private facilities in Bihar. And this, of course, has been also confirmed by other studies and other data. In terms of how well the primary care providers knew about managing or knew about their knowledge about COVID, they were generally well informed about the main COVID symptoms and its prevention, but they had very poor knowledge about the less typical symptoms such as loss of taste, smell, diarrhea. And these, at least in the Indian context, have become quite prominent lately. And so I think this points to an important area of communication that's required. The quality of medical advice that these formal and even public sector providers gave or said they would give appears to be poor, particularly things like asking history questions and the sort of medical advice they would give for symptomatic patients. But this could also be especially for the formally trained providers, an issue of sample size. We had a really small sample size, and so it may not really reflect or it's not representative in any way of the primary care, the public sector primary care providers. But the overall takeaway from this study for me was that it's important for informal providers to be engaged by government in the COVID-19 response. As we saw from the data we collected, they have hardly any contact with any government channels in terms of the sources of information on COVID. There's hardly any interaction with government officials. Yet they rely largely on the public system when it comes to referring patients. At least this is what they told us. And so, just to sum up, when you take a health systems perspective, it seems to me that when you have such a large health workforce, large primary care workforce that is present, many of them, most of them being informally trained, I think some sort of engagement with them by the government is important, and it could be something as simple as just giving information, if not any more formal sort of engagement. I'll stop here for now, and I'll hand it over to Garima. Thank you.
Thank you, Krishna. Let me see if I can, let's see, okay. There, how's that? Is my screen visible now?
Yeah, I can see it.
Okay, so I'm very glad to be here, like I said at the beginning. And I have quite a lot of slides, but I'm going to try to go through them quite quickly. Our objectives, our study complements Krishna's study in that we looked at facility-based providers at the primary care level, and our objectives were to understand the degree to which public health facilities were prepared for COVID-19 response, and to understand the changes in facility service delivery from the provider's perspective, and to document the effect of COVID-19 on the facility-based services in general, and to understand the health provider safety, wellness, and challenges that they were facing, and the degree of their resilience, and to try to capture any strategies that had been developed on the ground to mitigate the impact of COVID-19 response that they could share with us and that could benefit others. So this was, again, a telephone survey, and let me see. This was a telephone survey, and it was conducted roughly at the same time that Krishna conducted his survey. And I always have the disadvantage of when I follow Krishna, he has such nice slides. I'm now very jealous of the slide that he showed of the prevalence of COVID in Bihar when he was conducting the survey, and I must steal that from him and have that here as well. But basically, we were following Krishna's data collection very closely, and we began the week following his. And so the prevalence of COVID-19 was roughly the same when we were doing our data collection. And we were basically looking at a sample of the facility-based providers that Krishna and his team had identified in their earlier household survey. So of the public health system providers that they had identified, we reached out to a sample of those, and we reached out to medical officers in charge who manage the primary care level facilities, and the nurses who work in the labor room or auxiliary nurse midwives. Why isn't this slide moving? Oh, okay. Let's see. So we were successful in reaching 95 medical officers in charge and 90 nurses. And for the facility managers or MICs, this was a response rate of 48%, which is roughly what other studies are finding. And for the nurses, we had a higher response rate. We reached 89% of the nurses. And one of the things we asked these respondents about was how ready these facilities were for COVID-19 response. And we asked whether electricity and hot water were available throughout the day. And you see the dark column is electricity, the lighter column is hot water. And it doesn't, the shorter bar doesn't mean that they didn't have hot water at all. It just means that they didn't have it 24 hours a day. We also asked about connectivity and communication. And you can see from the different bars, we've divided the results up in terms of primary healthcare centers on the left and community healthcare centers on the right, which community healthcare centers, for those of you who are not familiar with India or with Bihar, are slightly larger centers which should be slightly better equipped, but often actually the standard is roughly the same between these two levels of facilities. But the interesting finding here really is the very pale column on the extreme right in both groups, the 96% and 100%, and those are the respondents who said they relied on other modes of communication other than a landline or the internet. And basically those are mostly rely on WhatsApp or a combination of WhatsApp with other methods, which is interesting, showing how digital communication like WhatsApp is replacing official channels. So these respondents were relying on WhatsApp to communicate with the district on official business. Now, in terms of contagion prevention, the green circles show you the proportion of respondents who reported that the facilities had been disinfected in the last week. 98%, or that they had designated hand washing areas for patients in the waiting area, this circle here in the middle, or that they had a designated hand washing area for the staff. These lower circles over here show you the lower percentages for having separate physical areas for patients in terms of this very low figure here, only less than half had a separate consultation room for patients who had respiratory complaints. And then these circles show you the proportions of people who proportions of facilities that were reportedly had separate waiting area for patients with complaints or an isolation area. And this is understandable because these are generally smallish facilities, not district level hospitals. We asked whether essential medicines and supplies were available, and the level was quite acceptable. These circles are for the primary healthcare facilities, and these are for the community health centers. And as we said earlier, these don't differ very much. There's an adequate supply of medicines and of supplies in lab reagents. We also asked about the frequency of disinfection, and we asked about facility disinfection, the ambulance disinfection, and what stocks they had of disinfectants. And as you can see, the facility disinfectant was quite high. The 98% reported that the facility had been disinfected in the last 7 days, and the average rate of facility disinfection was 13 times a week. The median was 8. Ambulances were not disinfected as frequently. Less than a quarter said they disinfected the ambulance after every use, and 6% said they only disinfected it when they suspected a patient had COVID. In terms of protection of staff, we asked whether staff had been trained, And these are proportions for what they had been trained on. So as you see, number one shows the proportions who had been trained on transmission of COVID-19. The second column from the left, the second group of columns, shows you training on hand washing and using masks. And the third here, number 3, is training on implementation of physical distancing norms. And the training on categorizing risk zone spaces as understandably less, as we said earlier, simply because of lack of space at these smaller facilities. 99% of the MOICs reported that all their staff had been trained on hand washing and using masks. But 53% of the auxiliary nurse midwives mentioned being trained on these different items: sanitation, COVID symptoms, COVID prevention, social distancing, how to treat COVID, and use of PPE. So those numbers, those proportions, as you see, are much lower. In terms of availability of protective equipment, where not all of the facilities, not all of the MOICs and the ANMs that we interviewed were at the same facilities, but for the numbers of facilities where these two groups of respondents were at the same facility, that's 72 facilities out of the facilities that we interviewed. We compared what the MOIC said with the ANMs in terms of what PPE was available. And you can see here that the green bars, the logo should say that the green bars are what the MOIC said, and the yellow bars are what the ANM said. So 50% of the MOICs, for example, reported that these 3 items were available: the gloves and the mask and the plastic apron, but only 24% of the ANMs reported that they had received these 3 items. One of the very important things we wanted to understand was what the impact was of COVID-19 on essential services. And these are the changes that were reported by the managers in terms of patient load and referral. And here, the pink line on the top shows that the patient load largely, very substantially decreased in terms of outpatients, and decreased somewhat less at the in terms of inpatients, and increased in a much lower proportion. Smaller proportions said that it was the same as before. And this fits very much with what Rajesh told us at the very beginning about people going to facilities much less frequently. The MOICs also reported changes in work patterns and essential services. So the majority reported changes in the shift rosters and in the burden of work, and in the mode of transport or referring patients. Smaller proportions reported changes in referral instructions and the destination of referral, and I'll talk about that more in a moment. Very few reported changes in routine immunization, and this follows a period when routine immunization had been almost completely stopped at these facilities because of complete lockdown. But this is our data collection period was when these services had been removed and so had been restored. And so that's why the providers are reporting that there is very little change in the routine immunization functioning. What about reproductive and maternal neonatal child health services? Now, the green circles show you where there was little change in terms of that 96% of the respondents reported that there was monthly antenatal care provision. This was going on, and that 80% reported that the iron, calcium, and folate was in stock, and 78% reported that these were being distributed to women coming for ANC. But 70% of the respondents reported that there was a change in the number of deliveries. And I'll go into more detail about that in a moment. So 73% of the respondents reported that there were new guidelines for conducting deliveries, and mostly these guidelines were dealt with sanitation and PPE and staff safety and social distancing norms. Now, did the capacity for delivery care change? And in terms of whether beds were available for women in labor, and whether labor equipment was available, and whether a delivery PPE kit was available, and the supply of labor and delivery medication was available. These were the responses. So the majority of the responses are in the blue line, the horizontal line here, which shows that for the majority of respondents reported that there was availability of beds for women in labor, or almost 72%, almost 3/4. Also, the labor equipment was available. Fewer reported, just more than half, that delivery PPE kits for the staff were available, and medication was largely available. Around a quarter reported that this availability had increased, and fewer proportions reported that they had decreased, with the exception of the PPE, okay, which shows that it had decreased substantially. Now, going back to the change in the number of deliveries, worryingly, this pink circle at the bottom, where 60% of the auxiliary nurse midwives reported that there was a decrease in the number of deliveries. 10% reported that there was an increase, and 30% reported that there was no change. The number of labor companions was officially decreed to be less by the facilities, and one person is now officially allowed to attend with the woman who is in labor. One family member. In terms of triage, about 37% reported that there was a change in triage procedures. And when we asked them what these were, I've hidden that slide for lack of time, but it's mainly either the nurse wearing PPE herself, or asking the woman who is coming to put on a mask, or asking the patients in general to maintain social distance. Those were the kinds of criteria. Now, about changes in delivery procedures, this is one of our worrying findings, because not inconsequential numbers reported that there were changes in the way they did these things. So there were 27% reported that there were changes in the way they conducted an abdominal examination, and a fifth reported that there was a difference in the way they did pervaginal examinations. Now, these are for women who are coming for delivery, so this is quite worrying. 10% reported there was a change in the way they gave IVs and just under a fifth, or 17%, reported a change in the way they gave injections. Now, we know from another study that we also conducted, a qualitative study of at different facilities, which was a facility ethnography, and where we asked providers how COVID had impacted their labor room services at great length, because we had the liberty to do so because it was an ethnographic study. And they reported that they were not touching the women as often. They were not checking the lie of the baby. They were not doing abdominal examinations. They were not doing pervaginal examinations as frequently, simply because they were afraid that the patients might have COVID. And so this is quite a worrying finding if this is what is happening here. And this is going to be one of the things that we are going to be exploring in the next round of our survey. In my hurry, I neglected to say that the findings I'm sharing with you today are the findings of the first round of our telephone survey. And we're going to be going back to these providers roughly every 6 weeks for a total of about 4 rounds to capture how things are changing on the ground, and also to explore some of these responses in depth. And this is one of the responses that we're going to be digging more deeply into. Like I said earlier, the reasons given for these changes in procedures was to keep the staff safe from infection. And the changes mainly involved reducing the patient load and implementing social distancing norms. Now, there were changes reported in referrals. About a fifth reported that they were referring women less frequently, and that they also changed the destination of referral, which is this column here. And this is often because the district hospital that normally women are referred to has been turned over, or have been turned over, to COVID response. And so women who suffer complications need to be referred to a different district hospital that is not exclusively dealing with COVID response. 90% of the respondents reported that weak newborn care was being provided, and there was largely the things that were needed in terms of beds, oxygen cylinder, and equipment were largely available for newborn care, as you can see from the lines in blue. Postpartum services under COVID mainly consisted of, the changes that were reported, mainly consisted of providing information about COVID-19 and importance of maintaining distance and providing more care. We asked the respondents, do you feel that women's use of care has been affected by COVID-19? And just under 60% said yes. And they reported that 75% of these said that less women were coming for care. And they thought that closed outpatient departments, lockdown, and the patient's own fear of getting infected were the main reasons fewer women came for care. Now, one of the things we're very interested in looking at was staff wellness. And one of the questions we asked were, how do you rate your levels of stress? And just under 60% for both groups. On the left, you see the medical officers in charge, and on the right, you have the auxiliary nurse midwives, reported that their levels of stress were either substantially higher or somewhat higher than usual in the proportions that you see in the chart. The major causes of stress, the green box on the left shows the main causes of stress reported by the LMICs, and they reported an increased workload as their main cause of stress, followed by physical fatigue, and the last major cause of stress was fear of COVID infection, which for the nurses, because often they are the main interface with the patients, the fear of COVID infection was the highest or most reported cause of stress, and the need to practice extra caution followed that. The LMICs reported that they were conducting staff wellness checks, and the circle in the middle shows you that they reported addressing staff exhaustion or feelings in some way. So 77 reported checking staff wellness, and 74% reported addressing this, but only 45% reported that someone had addressed their own exhaustion or stress feelings in any way. The LMICs reported that they addressed the staff exhaustion through interpersonal conversations with those under stress, allowing informal leaves, reducing workload of those under stress, offering counseling facilities, and having weekly meetings with their staff. One of the last questions we asked was, do you feel valued by the community in this outbreak? And the blue sort of curves show you that just under half reported that they did feel valued, highly valued, and just more than a third, or the green curves show neither high nor low, and then don't know or very little or not at all are the smaller curves in yellow, red, and brick color. Now, one of the last questions we asked, I think this is the very last question, in fact, we asked, what are the key challenges you're facing and what could be done to support you? Now, this chart is a little bit complicated, so let me explain it to you, but basically the gray rectangle on the top reflects the responses to the question, what key challenges are you facing? And the green circles are the proportions of responses by the medical officers in charge. So you see the large circle is the medical officers in charge reported that staff shortage was one of their key challenges, workload was another key challenge, and the public behavior of the public was another key challenge, and their own safety. The yellow circles are the responses of the nurses. So for them, workload, fear of COVID, their own safety, and staff shortage, and there are many, many other circles that would add up to the total, but we didn't put them here for clarity. Okay. Now the lower rectangle here, which is in light blue, answers the question, are there answers to what could be done to support you? And here, both the medical officers in charge and the nurses reported that they need more PPE and they need more staff. And the different circles show the responses by each. So the nurses valued, the nurses valued PPE the nurses valued PPE more. That was their single biggest ask, whereas the LMICs valued having more staff, or reported their need for more staff more. Now, what are our key messages? Well, clearly, providers reported that they'd received a new training and new guidelines. There were variable reports of health worker protection. There were staffing shortages. There was decreased healthcare use on the part of the community, and there were changes to delivery procedures. The providers reported different levels of increased stress due to either staff shortages, work overload, or fear of infection. And the main asks by the providers were more staff and more PPE. Now, our main takeaway is that the pressure of COVID-19 highlights the susceptibility of maternity care services And this includes reversing gains in healthcare utilization and significantly the use of evidence-based practices. Information on local solutions to these challenges will be solicited in the forthcoming round of the provider survey, as I mentioned. And we hope that these rapid findings can help identify the main issues and help develop effective responses. Thank you.
Krishna, that everyone's presentations were spot on. This was really an outstanding session for how to, I mean, the reality of how to deal with the COVID pandemic within the community setting here in Bihar. And all of the surveys that you folks have done are quite enlightening. For me, it was very enlightening. There's been, we're at the end of the hour, but there's been a couple questions that have come in. Krishna, you may have been responding to some of those, but one just came in. And I just thought we'd go a couple more minutes over so we could address some of these. I, of course, had many I wanted to also bring up, but one of them is, okay, this is the providers and all the issues they face. Did you ask if any of the providers did get contract COVID? Two, was contact tracing ever ongoing? That's one of the questions from our participants. And if contact tracing was being done, who was doing it? Was it the informal providers or the licensed providers? And three, any ideas about surveying the customers, the clients, the patients in all of this? So let me turn it back to Krishna. You can decide who should answer those, and then we'll go to the last question.
Okay, I'll quickly say something and hand it over to Rajesh or Karima. I think, to the best of my knowledge, contact tracing was done, but it was done by public sector health workers like ASHAs, ANMs. I don't think there was any engagement with informal providers or even formally trained private sector providers in that. So again, the pandemic response has been entirely in the public sector's domain, and that's the point I was trying to make. Rajesh, Karima, maybe you.
I would second, Krishna, what you mentioned. It was primarily the frontline workers and to a large extent, to some extent, engaging the self-help groups. No
Yeah.
engagement at all.
Yes, that's correct. I'll add to what Krishna and Rajesh said. There was a massive effort on the part of the primary healthcare level auxiliary nurse midwives early in the epidemic to do extensive contact tracing, going door to door in households, identifying who basically who had returned from another state. It's important to say here that Bihar has a very high level of out-migration for employment. And when lockdown happened, migrant workers returned to Bihar in extremely high numbers. And this put a huge burden, I think, as we mentioned earlier on, the primary care facilities in identifying who had returned where and tracing all their contacts. But this was mainly done by ANMs and later by ASHAs.
Great. What about any evidence for transmission to the providers?
We did not ask that question.
Okay.
But no, we did not ask that question is the short answer to that.
Yeah, no, that's fine. And what about surveys of the clients, of the patients?
There are other surveys going on by other partners, I think, for surveying, for example, women coming for antenatal care, mm-hmm. and what is happening with that. But we have not done that. We've only focused on providers in our study.
And your surveys are very comprehensive, no doubt about it. One of the participants asked, did you look at HIV, TB, or NCDs like diabetes, hypertension among the women attending the MCH services?
Those are typically not services that are offered at this level. I mean, this level is really very, very basic.
Yeah. How will we be able to educate the public in harassing the frontline workers, and how can we overcome this stigma? Nepal is your closest neighbor. That's one question which probably has some internal messages there.
Rajesh or Krishna, would you like to answer that?
Yeah.
Rajesh? Yeah, I'll take a shot at it. I think, I mean, it's not an easy question or straightforward question.
No, it's not, no.
But clearly, I think it's an important thing to do. You know, I think a big issue has been in India of the public-private sector interface. At the peak of the pandemic in Delhi, there were lots of reports, for instance, of patients being turned away from hospitals, being denied admission, being denied care, etc. And so there was a lot of anger against that too. So I think that answering that question is a complex thing, given sort of the pluralism in the health system.
Okay, I'm just running through the questions quickly. A&M reported a decrease in the number of deliveries. Is it because the women couldn't reach the hospital?
Sometimes it was because they couldn't reach the hospital because of lockdown, and also because they were afraid of infection. And there were rumors also spread that facilities had shut down, which was not the case.
How did the government approach augmentation to staffing shortages? Were there initiatives to increase the number of healthcare workers in the formal settings?
Well, there were no new staff were added, but basically all staff leaves were were completely canceled, and staff have been working, full out since the beginning of the pandemic.
Just to add to what Karima mentioned, so no new positions were created, but existing vacancies, they expedited the recruitment process and ensured that those are filled up, at least the critical ones.
Great. Someone wanted to know, I guess it's in reference to one of the previous questions about how do you define the essential services? What's implicit in that? Because like we said, the diabetes, chronic disease, HIV is not really built into essential services. Could you give a better definition for that? Briefly.
Yeah, okay. Well, we basically were looking at what they routinely provide, but we particularly wanted to look at what was provided in the labor room, because Bihar has very poor indicators for maternal and neonatal mortality and morbidity. So that's why we focused on those.
Okay. I think someone wanted to know about facility disinfection. Does it involve spraying, fogging, mopping, general cleaning adequate? Any specifics for that?
Largely mopping and general cleaning with more supplies of sanitation chemicals.
Excellent. Okay. We pretty much addressed most of these. They keep coming in. You guys really did a fantastic presentation. Have you also considered data collection from community members to support your findings? So that's sort of similar to my question about the clients. But how did the quality of service provision change during this? And maybe that will be in the adjunctive surveys that you were talking about.
Yes.
Someone asked, did the number of abortions increase? Premature deliveries because of stress of COVID-19 or complications of COVID-19?
I don't have any data on that. I don't know if Krishna and Rajesh have that kind of data.
No, I don't. But I also want to say one thing, that this was a telephone survey, and telephone surveys, and it's my first experience with this, they're very different, right? You've got a small amount of time to ask the questions you have to ask. And it's usually people, I think our experience was like 15, 20 minutes, and that's when people start losing interest in what you're asking them. So, you can't ask a whole lot of things in a telephone survey.
Yeah, true. I have one last question. This is for Rajesh, because you had sort of given the overall view of the current pandemic in Bihar. And while you were doing that, I did look up the numbers roughly. There's been 722 deaths, at least that's what's posted, and 140,234 cases. The case fatality then would be 0.5%, which is much lower than what's been reported in some other areas. Is it underreporting, or younger population therefore not having, or less comorbidities that are seen? If you were to compare this to Italy or the United States or some of the others, you'd see a difference in that mortality rate.
You're right. I mean, that's a question that, all of us are happily, facing with no clear evidence as to what could be the reasons. Yeah. And the points you mentioned are some of the, conjectures that people are making. But the good thing is that, fatality rates are really low. Those who are critically ill, moderate to, severe illness, that percentage is well below 2%. The number of people at any point in time either needing any form of oxygenation, ventilator, or critical care support, is very, very, very low. So that's providing some kind of a relief to the public response in terms of its preparedness at the facility level.
Excellent. Thank you for that answer. I have, all of you gave such great presentations, very informative. I have my own list of questions, but it is late, and I may email you with mine. I want to thank all three of you for just an outstanding presentation. As I mentioned in the beginning, this is the last one of this particular series, but we are going to pick up in a month or so with the new series, COVID and Beyond, the consequences of COVID in many communities, and how they're responding as we move into better treatment, better hopefully vaccination, and other issues that we'll be faced with. I want to thank all the participants for staying in there beyond the hour, asking very many important questions, and for being with us through the entire series. Thank you very much. And I wish everyone a pleasant day and a pleasant evening. And thank you very much for joining us.
Thank you.